We're clicking broadcast, so we're letting people in now.
Okay.
Hey, Paula. Morning.
Paula.
Hello.
I just got a
How's
message
everybody?
from my students that they weren't getting the link that wasn't working for them, so I've resent it to them.
Okay. Well, that's a problem.
Yeah, that means all the staff as well, John?
No, it should. I saw it go to the staff. I don't know if I sent it to Xana. Maybe that was my mistake.
Some of
No,
ours
she
are
did not
coming
get
in.
it. She's sending it now. So she's sending this link now. So it'll be a couple minutes while they all register.
Okay.
So my bad. I sent it to the wrong person.
All right. So we're gonna plan for a 5:40 start time, 5:40 a.m. start time.
Okay.
Awesome. Yeah. Our students are coming in, all of them. Okay, good. Excellent.
Are your students filing in?
Yeah,
Trickly.
I think it's probably Robles is probably what like it's probably 5:30 for Celine. So I don't think we're.
That's
gonna catch
true,
him.
yeah. He'll probably won't make it.
One of our colleagues is in California, so he.
Oh.
I don't foresee him being away.
Oh,
Probably
yeah,
not.
so for his lockdown, he went back to California, huh?
Yeah. Skate.
Good morning, Jill.
Good morning. How are you?
Good, good, good.
Good.
Okay.
So, hey, while we have the educators on the line, we're working on a project which it actually I think it's a pretty big deal. The movement towards selective caries retention is what we want to call it. So we like to call it the learning center selective caries retention, away from 100% caries removal every time, basically into the pulp. That's how we were taught, or some weird like, well, get really, really close and get pinhole exposures, that whole thing. But selective caries retention as a default part of the modern cavity preparation, because we're building into this, these Clark cavity preparations. If we're going to be doing selective caries retention, we need, I think we should either be in or out, and we're in. When the research is that we've done, and everybody's practices, it's doing this, has been an incredible patient-friendly procedure. So, at Dr. Drummond, John, at McGill, selective caries retention, what is the current? Is there a standard?
There's no standard, but we're telling them it's better to leave a little bit behind than it is to get any form of pulp exposure.
Okay, so
we're on board with that concept.
So a pulp exposure is a mistake.
Yeah.
Yes.
Yeah. So don't do it.
Really.
All right. So what we're building is what everybody's telling us is we need a rubric, right?
Be nice.
And it's complicated because we have young patients and old patients, totally different, right? Huge pulp chambers, and then primary teeth, it's completely different. The pulp chamber and the primary tooth is just throbbing, right? So we're going to have a presentation next week. We're going to do deep margin acquisition and selective caries retention.
Nice.
For both schools. So, and we're going to be doing a survey. We're going to do a formal survey that we're probably going to publish, and then just a phone survey with all the schools that we're working with. So at McGill, it is not recommended to expose the pulp. You want to leave some decay, but there's not a definitive rubric on how much, right?
No, there is not.
Okay. Would that be helpful?
Yes, definitely.
Yeah.
Definitely.
Dr. Robles, Dr. Lawson.
Yeah. In Alabama, I teach the operative classes, and that's where we go over, we call it pulp protective excavation, meaning
Ooh, I like that.
Anything that
pulp protective excavation.
Yes, that's what I tell them in class. And so the excavation is to achieve proper seal, clean enamel, clean peripheral dentin, but over the pulp, affected dentin, leave it on.
Don't
never risk it.
That's very progressive thinking, and the United States is actually way behind on that. Most other countries were doing this way before the United States pushed for it.
But I have to tell you, it's a battle, uphill battle, because the people that cover clinic, 90% of them have this mindset of go to the pulp if it gets there, and we'll do the root canal. Yeah.
Dr.
Yeah.
Bustamante, Rafael, are you listening to this? see, Dr. Bustamante is heading up this committee to do we're doing a lit search on this and putting together the research is unbelievably successful. I mean, very few things are as successful as selective carriers retention. Incredible, 95%, right? And so so this is great, Dr. Robles. We're there. There's very little standardization across the board and basic operative things, right? There's disagreement within the schools and then between the schools. It's crazy, right? So that's been our mission. Nate, any thoughts there? Is it time? We got 3 minutes.
Yeah, we had so Robles and I wrote an article about selective caries removal for decisions in dentistry. And so, yeah, I think that like affected dentin is going to be easier. I know there's some people talking about leaving infected dentin if it's going to prevent you from entering the pulp chamber. I don't know that one is going to be as widely accepted in the United States, but yeah, I feel like I think affected dentin makes a lot of sense, and I feel like how about like have you guys talked about chlorhexidine or something like that, or is that something that's come up in the conversation of like anything to put on the affected dentin? Or
here we go.
Yeah.
Okay. No standardization, right?
Yeah.
And one of the most important things that we should probably figure out. So Nate, that's a conversation that I'd love to continue and include all the schools in, because it's all over the place. And it's a very lengthy conversation, and there's some pretty good science in that. And that's so that's what we're going to be doing next week is selective caries retention. What we're teaching at the learning centers, and what a lot of the schools are teaching. We're going to answer a lot of your questions, but in a more holistic way. Does that make sense?
Yeah. No, that's awesome. There's a pretty good. I think Iowa, like University of Iowa, has they had a protocol published, and then so does then there's the selective caries removal endpoints from Allman and Meunier that they've got a kind of a protocol. So those were, but they were a little bit different, but kind of similar protocols.
Yep.
Schwendick and others from Germany have also nice protocols published. Modern protocols actually studies done on success. So
yeah,
plenty of literature. Yeah.
Yeah, plenty. Yeah.
That would be great to see.
Good.
Something.
So we're planning that for next Friday, 5:30 West Coast. Right?
5:30 a.m.
Oh yeah, the same time.
Yeah, why not? I mean.
Yeah. So are we good for next week this time?
Yeah.
Yes?
Let me see.
Yes, I am.
Okay, perfect. And McGill, Taras, we already talked about doing the.
Yeah, we talked about it. So John, do you think we can get a slot next Friday?
I don't know if I couldn't get a slot for one of my other lectures at all next week, so I don't know if we have a slot available for us next week. Okay.
Well, I'm more than happy to do it for Alabama, and if you two can figure it, if McGill can join us next Friday, that would be great.
Yeah.
Because like I talked about when I think Dr. Robles, Dr. Konings was out there at Alabama. He talked about.
I may not be able to get the students, but I could probably get some of the staff.
Okay. Well, yeah. Either way.
I can invite faculty too. I mean, if that's a possibility, I have a couple of faculty that can reinforce the concepts in clinic.
Right, but we literally have to have the students, because what I found out was when I went to Roseman and when I went to Montreal, and I've been talking to all of you, that dental schools, because of the patients that you get, you're doing unbelievably difficult composites. You're taking out old bad composites, deep decay, old amalgams, and doing bigger, huge composites. There's not these board composites, right? Yes. I was blown away by how tough those cases are for those kids, right?
Indeed. Yeah. Indeed.
So we got to talk about cuspal overlays and compression joints and deep margin acquisition, all the cool stuff. I love nasty composites. So that's what we're going to talk about, because that's what you're doing, right? Yeah. And Taras, same thing, right?
Yep.
Yeah. Okay, cool. Good. All right, it is showtime.
Yes.
How we doing on students? 132. We'll take it.
Good morning, Dr. Clark. It's Chuck.
Good morning, Chuck Hudson. How are you?
I'm good, thank you.
All right.
Yeah, I was on another conference call. I was a few minutes late. Sorry.
Great.
Hey, Chuck.
We waited for you.
That's
Yeah, the 150 people.
it.
Now that Chuck's here, we can get started.
Excellent. Like to hear that. Morning, everyone.
Good morning.
All right. So I want to welcome our two schools. It's, we've had a lot of fun pairing schools. I mean, McGill and Alabama are pretty far apart. We're going to need an interpreter, right? Because we got Francophones and then we got Southerners, right? So this is great. And a lot of the schools have appreciated where we paired them together. And it's been great. There's a lot of conversations that have been pretty exciting. So we're going to jump right in today. This webinar was really initiated by Dr. Taras Konanek, who's a visiting instructor at the Learning Center. He's been implementing the Bioclear method up there at McGill. And we've had some conversations with the folks down at the University of Alabama, Dr. Robles and Dr. Lawson. Dr. Drummond has visited the Learning Center at the last Educator Summit. We have Dr. Rafael Bustamante on the line, who is faculty track and visiting instructor for the Bioclear Learning Center. So first I want to check in with all of our panelists just to say hello. We're going to be asking for them to be giving comments. Dr. Bustamante will be answering questions. We have two ways for you to be asking questions. There's a Q&A session where you can answer questions, and if you have any technique or if you're confused about some of the lexicon, the words that we use for the Bioclear curriculum, you can put those in the Q&A, and Dr. Bustamante and Joe Carroll and some of the other folks can answer some of those questions. We're going to be quizzing the students. I'm going to ask questions, and then the students are going to answer that. That's going to be in the chat box if possible. So is that correct, Carissa? Yes. So, but if they end up in the other box, that's okay. But I want to make this interactive. I want to have you I want you students to be asking questions. When I went to dental school 194 years ago, we did gold, we did amalgam, we were fussy, we did gold foil. I loved margins. I've got a microscope. It was awesome. And then they introduced this white stuff, right? It was junk. We thought it was junk. I hated composite because everything I saw a guy do a lecture. He came to Washington, and we were the gold and amalgam freaks, right? So this guy gave a lecture in Seattle, and he was this new white filling guy. And somebody in the back of the room raised his hand, and he said, "How long do you expect these things to last?" And the guy says, "Oh, about 5 years." We booed him. That's the first time I ever saw a guy get booed in a lecture because that's not going to work. Just because it's white doesn't make it good. Well, it's been a journey. And I'm going to tell you that we have created, and the world's been working on better ways to do this. And we're going to be talking about the Bioclear method to have the same standard that we had with gold, with 20 and hopefully 40-year outcomes. But the difference is, when I did dentistry in dental school, I was the boss. Nobody complained about aesthetics because we had silver fillings and gold. Now the patient's going to judge you. So we're going to focus a little bit about anterior aesthetics, because no matter how well the restoration fits, if it looks ugly, it's a failure. So we have the challenge of being very careful with our restorative dentistry, thinking in terms of good science, but at the end of the day, if it's ugly, you fail. So it's fun. It's great that it's a challenge. Hey, if it was easy, anybody would do it, right? So being a doctor is fabulous, but it's different, and you have to balance all these things. They're all important. Aesthetics and the long-term functionality, we have to nail it. So with the Bioclear method, what we found is we can satisfy longevity, health, and aesthetics all at the same time. They actually work together instead of against each other, which is cool. So let's just jump right in. And if I could just go around the room and have the attendees just give us a quick background, because we're combining the two schools. Dr. Taras, do you want to go ahead and say good morning?
Of course. Yeah. Good morning, everybody. It's so nice to see so many people on the line. As I mentioned to you, David, when we were talking yesterday, this has just been so nice, and it's the first time that we're actually having collaboration with other schools. You know, with an American school, this is monumental, and it's all because of the time that you're putting into it, David. So we wanted to thank you, and we wanted to thank, you know, the Bioclear Learning Center, and just thanks for bringing us together, bringing sharing of thoughts, and like you said, and the most difficult thing is getting unity in what we are doing clinically. I think we can all agree we want the best for our patients, we want the best outcomes for our patients, but there's so many ways to do that. And I think one thing for me that the Bioclear method brings is that we are able to do it without touching the teeth. I don't want to cut teeth anymore, and this is why I'm here, and I believe that the university has to be doing this.
All right, Dr. Drummond. Thanks, Taras.
Echo Taras, we're trying to get this process moved forward with McGill, just because of the dynamic nature of changing the way we do things to make things better and more strong and better for the long term. So I appreciate what Bioclear has done for McGill so far in getting Taras and I trained, and now it's our job to take it to the next level, trying to get A, the students, and then B, the rest of the staff coming on board. So we appreciate the support Bioclear's given us, and I think it's an awesome project to take forward.
Thanks, John. You know, one of the neat things is I was just this crazy inventor living up here in the woods, you know, and then over the years we have a community working on this, and now we have these great partners. 3M has done an incredible amount of research. We'll send that for you to look at, and we have Comet Burrs that's helping us to. We've got this great burr kit for these modern preps. Comet is giving scholarships away for. We'd love to have a student from Alabama and a student from McGill come to the Learning Center. They're writing a tuition to have one student come, second-year student, to become a champion in your school and come back and help sort of get people excited about it. So we have the support today for the schools that we didn't have 10 years ago. So we're here. We're here to support you every step of the way.
And we appreciate it. Thank you.
Great. Okay, Dr. Lawson.
So hey, for those of you from McGill, my name is Nate Lawson. I'm our director of biomaterials. So I'm a dentist, but I do a lot of biomaterial stuff. I was telling Dr. Clark the other day, so I remember reading about, opening up this, what was it, Dentistry Today magazine when I was sitting as like a first-year dental student for whatever reason, opened up the magazine. And as you know, in first year dental school, all we learned how to do, well, we spent a lot of time learning how to do amalgam preps. And I remember looking at this guy from Washington with the crazy hair, and he was doing these preps that didn't look like these little holes that I was making when I was, you know, trying to make these amalgam preps for my faculty. And I thought, who is this guy? He's saying we don't have to make these weird looking preps that never made any sense to me. So that was my first impression of Dr. Clark. And then I've gotten to see him numerous times now give his presentation about Bioclear. So I told all the students at UAB how excited I am to get to hear it and how cool I think this presentation is going to be today, because he's just such a fun speaker. And so I'm really looking forward to it. One thing I do want to say, because I've gotten already a lot of emails about this, in this format, we can't see you guys or hear you. So don't worry about what you're wearing or saying. So, but thank you so much to all the sponsors and for Dr. Clark for putting this on for us today. And I'm really looking forward to it.
Great. And then Dr. Robles.
Dr. Clark. Well, kind of like the same story with Nate. I got this picture of your diagrams of preparations on a journal. I think it was the Inside Dentistry, where you had the traditional, GV Black and then yours. And I was using that just to show all the other colleagues that I had at the school, we don't need retention. Stop it with the mechanical retention. We're done. Move on, please. And they look at me like I'm a weirdo. And eventually I got to direct operative. So I started implementing this, and I'm very happy that you're leading this, and we're excited. I can't wait to have this incorporated at UAB. I'm telling you, it's this transition time that I was mentioning before in our conversation, but I am excited. I want to see this implemented for sure.
Great, great. So it's a movement that has to happen, students, faculty, everybody together. And without this push of energy, it was going to take forever. We're seeing real movement now. We're seeing real movement. And so it's a huge community to do this, right? Great. Okay. We've got Dr. Bustamante, if you just want to go ahead and say hello. Rafael?
Good morning, everyone. I am wearing headphones because my family is still asleep on this side of the continent. Just wanted to say hello. I'm excited to be here and thank you for the opportunity. And I hope that I can get to your questions and give you some answers that are clear and help you understand the method better. Thank you.
Great. We've got folks from, we've got a bunch of folks from Clinical Research Dental and Bioclear and 3M and Comet on the phone watching. I want to welcome and thank all of those for all the support that you've given to for all the research and for teaching. The generosity of all these companies has been incredible. Hey, let's just jump in and get going. So let's go ahead and go to full screen. And once again, ask questions in the Q&A, and then we're going to be asking, we're going to be quizzing the students as we go along. And there are no prizes this morning, okay? All right. All right, so full screen, there we go. Now you have the ability to go in with your little mouse and drag your screen around with your, I'm dragging the screen of all the panelists around. You can minimize it. So if the panelist screen is in the way, let us know. Go ahead and email Carissa with any technical problems, and then go ahead and get a hold of, and like I said, if you have questions about, now I've got the runny nose. If you got questions about the procedures we go along, our panelists will help answer those. All right, so let's get going. So these are our 4 learning centers. We have one here in Tacoma. We have a learning center in Solihull, England, Varberg, Sweden, and now Cairo, Egypt, where the curriculum is standardized. We teach the exact same way. We all use the same lexicon. And then the great thing is 3M is doing research on the Bioclear method. And most of the principles, the Bioclear method, most of the major principles have been validated in research that 3M has done recently. And of course, the ultimate test is clinical success. And that's great that we have one of our visiting instructors here to talk about that. So here's our faculty, and we've got some of our instructors here, and then we've got some of our visiting instructors. You'll notice Dr. Taras, Dr. Carolyn, Dr. Raphael. These are some of the folks up here in Canada that are doing coursework for Bioclear and working with the schools. And so this amazing community it's been fun, and we welcome you, to this great family. What I hope, did we get a chance, Dr. Robles, Taras, to send this YouTube video? I think it's a great summary of the Bioclear method and compression.
We send it out to our students.
Okay, watch that. We worked really.
Yeah.
So you did send that out, Nate? Yes.
Yes,
send it
we
out.
did send
I don't
it
know
out
if they
to
watched it,
students.
but
Hey, they have to watch it. And the same thing, McGill. It's a great summary of the method. It's really compacted, I think, pretty nicely. So let's make sure that they watch that. These are the dental schools that we're currently working with. We're going to need to add University of Alabama, if that's okay with you, Dr. Robles, Dr. Lawson, as far as you're in the investigation phase. So, welcome to the family. We want to once again thank the folks 3M and Comet and Bioclear that are helping to integrate this whole new Venn diagram. And today we don't have time to talk about the Venn diagram. Dr. Konanek says, David, we're showing basics of Bioclear, and Dr. Robles will send you all of the materials that Taras has. Today we just wanted to wrap it all up together and say, okay, on Monday morning when we get up and running, how do you do this, right? It is a recipe. Bioclear is a simple recipe, but the steps are important. I want to put the steps together in a meaningful way. It's the putting together of the steps that's the trick, right? Remembering the steps, what order and why. That's what we're going to do. So we're just going to do a bunch of procedures on Dentiforms once we get going. You can, if you want to go ahead and email solutions@bioclearmatrix.com. We've got a bunch of folders, lots of videos, lots of articles. You can get a lot of those PDFs of the lectures, and then I'll send the lectures to to both schools, actually the actual PowerPoints on these. So if you email solutions@bioclearmatrix.com, you'll get a link, and then you can down and get in and kind of peruse all these different folders. You have to kind of look around, but there's a wealth of information there. All right, so we have all these challenges with direct composite. By the way, folks, you folks in Alabama, it's composite today, okay? Because we have some Canadians, right? It's composite. So a lot of dentists that are in practice, and it's kind of sad, a lot of us dentists in practice, we have so many challenges with composite that we give up. We try it, it breaks, the patient complains, and what do? We do crowns, because crowns are easy. And frankly, I mean, crowns have become kind of a low skill procedure. I mean, anybody can do a crown. You just grind it down to a stump, and the ceramist figures it out. Well, the physiologic cost of a crown is high, and the cost of a crown is high, but the physiologic cost is a bigger deal. One of our faculty members, Dr. David Carroll, he's a prosthodontist. He says the problem with crowns is nature doesn't make a tooth the shape of a crown prep, right? Nature doesn't make the tooth the shape of a crown prep. It's the path of insertion that kills direct. We have to grind everything out of the way to get path of insertion. If it wasn't for that, it wouldn't be so bad. So patients are demanding a third option. I don't want a crown. They can afford a crown. Sometimes they say, I don't want a crown. I had a friend that got one. I got one. I had a problem. So I don't want to bash on crowns. Crowns are great, but we need another alternative that acts like a crown without the physiologic cost. So what I'm putting up here is a before and after of a posterior case and an anterior case. And we've been doing this long enough, and I'm doing an outcome study on non-retentive class 2s, the Clark class 2. On the top, you see some teeth that had large amalgams. The teeth were cracked. Patient was asymptomatic, and I told a friend of mine, Jim, I said, hey, Jim, let's do some crowns, because crowns are great, and your amalgams are failing. He says, hey, they don't hurt. I don't want crowns. And he's my friend. And I'm saying, hey, do some crowns. And he says, no, I don't want crowns. So we waited and waited. And finally I said, Jim, I have a new procedure. We don't have to drill your teeth down. We're going to do these overlay preparations and put your teeth into compression. He's kind of an engineer. And he goes, that makes sense to me. So there's a 10-year post-op of calla lilies and cuspal overlays. We're going to be talking about, for those of you that can join us next week, about large amalgams, deep margin acquisition, selective caries retention, and cuspal overlays for root canal teeth and cracked teeth and broken teeth, and treating old failing restoration. So at 10 years, this does not look like bonding anymore. So this is not bonding. This is the Bioclear method. On the bottom, you see some black triangles that I treated. This was an orthodontist that flew out from New York. She had these black triangles that she hated, young lady. And she says, I love my enamel. Can you leave the enamel in the middle of my tooth, but just add to it? So the goal of the Bioclear method is, number one, preserve and respect the natural tooth volume and biomechanics. You put a tooth on a crown or do anything like that, you cut a tooth, it's never the same. You do endodontics, the tooth is never the same. So we want to preserve the biomechanics. The best way to preserve the biomechanics is don't cut the tooth. And if you do, let's understand engineering. Number two, to replace the missing, the diseased, the worn tooth structure, which is what people want. And the third thing about the Bioclear method that kind of gets people stirred up is we want to thicken and opacify the aging, thinning tooth. Now, there are a few dentists who say, oh, you need translucency, we need thin teeth, we need dark gray teeth with stains. Let me tell you, almost nobody wants that. Why do we bleach our teeth? To make them look opaque. Okay, so the Bioclear method thickens and opacifies the tooth and brings the value up. Here's a little clue, doctors and young doctors to be. The whiter the tooth, the more you can charge. Okay, now we're not going, we're not a doctor to make money, okay, but we have to have an income. Patients want aesthetic dentistry. You're giving them everything they want. Patients say, are you kidding? You can take my tooth, not drill it down, fill in the black triangles, and bring the value up, brighten my teeth, because I tried bleaching and it didn't always work. And I say, yeah, I can do that. And then the patients say, what's the catch? And then I say, what's the catch? We have to retrain the world. That's the catch. Because everybody thinks that the crown's the way to do it. Well, the crown's the easy way, right? So we're going to do it a different way. Cool. All right, here we go. So I invented the Bioclear back in 2007. It was a matrix. And I'll tell you what, I drug out, hey, not Nate, I got out a piece of flat Mylar the other day. It was miserable. Not only is it the wrong shape, it fights against you. Literally, the Mylar is fighting you. It hates you. Right? I don't know what I was doing with that flat Mylar. Anyway, the matrix works for you. It reflects the soft tissue. And then all you got to do is, what do I do next? How do I work around this amazing aquarium? All right. So let's show a case and have some fun, and then we'll get rolling. Okay. So here's a case I treated, identical twins, except they're never quite identical. And so Double Trouble had twins with peg laterals. So here it is. This is an article I wrote in Dentistry Today. That's available on that website, and the video that I shot when I did the case is on the Dentistry Today website. So here's the twins. So here's our first quiz. And a lot of you don't take photography in dental school. I know at Loma Linda, Richard Young has been very aggressive about getting cameras to the students. So getting a camera would be really great. Anyway, we took a picture of the twins, and the story with the twins is the orthodontist sent the twins to me and said, can you do some bonding on the lateral incisors? Can you do some bonding on the peg laterals? And I didn't like bonding back when bonding was kind of, you know, it was all we had, but I love injection overmolding. And so I told the orthodontist, I said, well, we're not going to do bonding. We're going to do injection overmolding. And he says, okay, where do you want the peg laterals? I said, I don't care. Just put them in the middle. He says, you're kidding. Some people want them toward the front. Some people want them toward the back. I said, I don't care. The whole case is undersized. I'm going to injection overmold in a different way. I don't want to steal my thunder here. So anyway, the twin on the left, what is she doing with her tongue? The twin on the left, let's ask our students, why is the twin on the left putting that tongue behind her teeth? So let's open up the panel and ask students, why is the twin on the left putting a tongue behind her teeth? So let's see it. So this is, we want this in the chat, not the Q&A. If it's in the Q&A, oh, here we go. Okay. From Mansi Pabari, tongue thrusting, and then by Dula, to hide the black holes, to cover the space, to compensate for black triangles, to camouflage embracers. Yes, okay. When we ask practicing dentists, most practicing dentists, their brains get contaminated by listening to too much CE sometimes. So a lot of practicing dentists say it's a tongue thrust problem. It could be, but that's not what it is here. It's a problem. It's called absolute luminescence. So these kids or adults figure out, I don't know how, that if they put their tongue behind their teeth, that it softens the contrast between white and black. So the contrast between white and pink is way less harsh than white and black. So they realize if they have incisal edges that they don't like, if they have black triangles or any unfamiliar negative space, by putting their tongue behind the teeth, it looks less bad. It's kind of sad, really, for mom, you know? So treating these cases is one of these feel-good things that you're gonna love to do. All right, so yes, she was hiding her negative space. So next question, dental students. Remember the 3 goals of the Bioclear method? We want to replace the missing. She doesn't like her thin gray teeth. Not everyone has thin incisal edges. So we're going to do additive dentistry potentially on her and change not just the peg laterals, but change a life, right? But when you look with a lateral view, and that's what you have to do if you want to do comprehensive aesthetics, is we have to start taking photographs and then looking at the case and thinking about it in a more scientific way. So let me ask you, dental students, can I just do bonding on the peg laterals? I mean, when you look with a facial view, you think, okay, fine. You look with a lateral view, is that going to satisfy basic smile design? Is that going to look okay? So let me ask you, dental students, for these twins, and there's 2 of them, teeth are about the same, what is your treatment plan? How many teeth are you going to do? And how would you do it? So we've got these twins. You get to practice on the first one, right? I'm kidding. So what are you going to do if you've studied anything about the Bioclear method, okay? And here's the thing. Mom says, I'm not super rich, but I love my girls. And you tell me, Dr. Clark, if it was your daughter, your twins, what would you do We want to do the least invasive thing. We want to try and not always just throw dentistry on everybody's teeth. There's a balance here, right? So what would be the most conservative thing, the least complicated thing, but not to compromise on the beautiful smile of a 13-year-old girl who has she's embarrassed about her teeth. We got to knock it out of the park. We got to put the hockey puck in the net or whatever, right? So how are we going to do that, students? Give me your treatment plan. Go. And don't tell me 6 crowns. She's 13 years old. It looks like their teeth are not fully erupted, okay? But look at where the lip is. Look at where the lip is. Is that a problem, okay? What is occlusion like on the canines? Are they coupled? Yeah, they're pretty well coupled. Yep. Treatment plan. Okay. Oh, see, they're hedging their treatment plan by asking more questions. These are smart students. They want to be right. I like it. So we've got one. Hugo saying only treat the pegs. Okay. All right. That's one treatment plan. Adding Bioclear on both mesial and distal sides of the peg, laterals on the canine if the space isn't properly filled. Okay, so somebody's saying, hey, maybe the canines, right? So somebody says just the pegs, somebody says the pegs and maybe the mesials of the canines, okay? So I got another plan. I would do 4 teeth, laterals and centrals, but not the canines. Now I got one who does the pegs and canines. Gingivectomy and anterior 6. Okay, Corey's going to go for it. Okay, Corey's saying rock on. Let's just do the whole sextant, right? Yep, 3 to 3, 3 to 3. Okay, good. All teeth from canine to canine. All right. So we're going to go ahead and this is perfect. Okay, these are all reasonable treatment plans. But what I did in this case was I injection overmolded all 6 teeth. One of the things about I see a lot of folks talking about gingivectomy here because the teeth are not fully erupted. These kids are 13 years old. We're not going to do a crown lengthening on that. One of the neat things about the compression with the rubber dam when you blast the teeth, and then the Bioclear matrix, you notice from the photo, it pushes the gums up. I'm gonna lift the gingival curtain just with the Bioclear method, which is easy to do. I can push the gums up about 1 millimeter, which is all they need because the lip on these kids is not very high. Gingivectomies only matter if the lip is up here, okay? We need a patient-centered outcome. We see too much sort of knee-jerk dentistry in the world. So if you look at the lip, on these kids, she's not really showing a lot of gum. So I'm not worried about the gingival level, even though I am going to push it up with Bioclear. We're going to be fine, okay? All right, so here we go. So these are the matrices that we're going to be using. And so we have classic Bioclear, original Bioclear, and this webinar is being recorded, so you can watch it later for explanations on Bioclear. It's basically 01, 02, and 03. The 01 matrix is great for the mesials of the central incisors. It's a very big, very flat matrix. The 02 is very curvaceous. It's good for Korean teeth. It's rounded from incisal to gingival. And then the 03 is a very small matrix for lower incisors or small lateral incisors. And then there's the pink and the green. The pink has a little hip, or orange for the francophones, and what is it in Spanish? What's the hip in Spanish? It's not barriga, that's a belly. What is it?
Cintura.
Cadera.
Cadera.
Cintura.
The hip. Okay, the hip. So the hip on the green is about 1 millimeter. On the pink is about 0.5 millimeter. So pink is for normal teeth. Green would be for big black triangles or big diastema closures. But it's 01, 02, and 03 are the main ones. All right. So I'm going to take an 02 and do a little trim there. Trimming a matrix is a pretty big deal. And that's something that your instructors can work with you to make sure it seats. This is the Bioclear aquarium. So this is from a video, actually. I've overmolded the central incisors. Then I use the smile design gauge. Can I see the smile design gauge? I use the smile design gauge to make sure that the central incisors were identical twins. And then we moved on to the laterals. And then we did the canines. There's the aquarium that we put around the tooth. So I noticed that one of the students says, put some composite on the mesial and put some composite on the distal. Taras, is that how we do that anymore? Putting a little composite on the mesial, a little bit on the distal with Bioclear. Is
No,
Taras-
well, we're gonna want to do this all at once and make a monolithic restoration.
we're going to injection overmold WST the whole stinking tooth. And that's where we leave the old world behind. When you do that, it's actually faster, simpler, better. I know it's hard to believe, but it is way easier to injection overmold a tooth and sculpt it back than to patty cake and add stuff all over the place. And that's going to stain, doesn't work. And that's why people don't trust bonding. So injection overmolding is going to set you free from those old handcuffs. All right. So here we go. Here's pre-op. There's what's called delayed wedging. We're not going to do that today because Taras wanted to focus on basics, but we can do this at another time. With a peg lateral, we etch, rinse, after we disclose and blast the tooth, we etch, rinse, and dry, and then we put a little hip of 1 millimeter with flowable composite that's Filtech Supreme Flowable. Put a little 1 millimeter hip around the tooth. I'll pull the matrices over, they'll light cure it, and now once the hips are set, you're going to put wedges in there. It's called delayed wedging. And then you pull the matrices apart just a little bit because the teeth move. Then you injection overmold the whole thing. It's called delayed wedging. There's a video on YouTube that's got 1 million hits that shows you how to do this diastema closure with Bioclear. You can watch that. Anyway, there's the post-op. So that's WST, whole stinking tooth. So did I satisfy the method? Respect, I didn't cut the teeth at all. You see I was able to push the gums up with the matrix a little bit there. And that's a beautiful monolithic result, right? And Filtech Supreme Ultra has this magic blend of translucency and opacity so that makes it easy to do these cases without any layering. And so here she is pre-op, here she is post-op, and here are the twins. Now this is kind of fun. The twin on the left had the treatment done on Tuesday. The twin on the right, it's Wednesday, and she's about to get in the chair. I thought it was fun to like take a video of the two of them, right? This is a gift that keeps cycling. It's almost kind of creepy, isn't it? So the twin on the left, she's just kind of now, can you see she's just maybe now getting their lip to come up a little bit because she's not embarrassed of her teeth. Isn't it cute? I mean, you only get to treat a pair of identical twins once in your life, right? So try not to mess it up, all right? So here we go. Yeah, let's keep running that thing. Okay. Here we are pre-op. Here we are immediately post-op. I think I might have the twins reversed. I can't keep them straight. Mom says she can. I don't believe her. No. So that's immediate post-op. Here they are 3 years later. So it's transformational. And here's the funny thing. Let me back up a little bit. There are aesthetic academies where they go, wah, wah, wah. David, you need to wah, wah, wah. You need to put in this. You need to put perichymata. You didn't do this. You didn't do that. Let me tell you, folks. The twin on the left won best smile in her high school. Isn't that such a weird thing? Best smile, most likely to go to prison, most successful, best hair. Isn't that crazy? Do they still do that in high school? I don't know. Anyway, the twin on the left won best smile in her high school with 1,000 kids. I'm done here. I mean, if she won best smile in her high school, Mom says that when they got this work done, that people would stop them in the street and say, your twins have the most beautiful smiles I've ever seen. It's a beautiful patient-centered outcome. And you're going to hear a lot of negativity in dentistry where, oh, you need to do this and that. If your patients are in love with it, if you were incredibly conservative, let it go. Don't listen to the naysayers. Listen to your patients, listen to the pulp, listen to the soft tissue. We have a lot of different philosophies in dentistry, and so I'm excited that you're hearing this. So anyway, here we are at the 3-year follow-up. I mean, how many selfies does a girl take a day? You know? A lot, right? I think my son takes even more, but here's the 7-year follow-up. Now they're young ladies. Monolithic composite is pretty incredible stuff. We looked at some of the studies with this millable composite. Now we don't use millable composite because it has some of the disadvantages of crayons, but millable composite has the same compressive strength as Emax press. It has the same compressive strength as Emax press. It's tough stuff when it's monolithic. So the studies that were done supporting monolithic are pretty impressive. Anyway, it satisfies, really, it satisfies everything that your patients want with the recipe. I've never had a patient really have problems with the color and the translucency of these monolithic restorations. So in the old days, here we had this flat piece of mylar that I was fighting with. I was telling Nate about. The problem with the mentality of where we've been is we have all these amazing composites and kind of a dumb delivery system, right? And so the manufacturers figure, hey, it's our job to figure out how to deliver it, right? So Bioclear was really taking the composites from the lab and putting it on around the tooth in a more predictable way. So the problem is when they handed me this flat piece of Mylar back in the old days, they gave me a wooden wedge. I put that flat piece of Mylar on there, put that wooden wedge in there, and I thought I had a great margin, because remember with gold, I was obsessed with margins. I had this beautiful margin. Of course, I got some finishing to do on that tooth, but I remember finishing this case as a guy out of school, and I took the floss across the margin and said, isn't this awesome? Your margin is so great. And the guy says, hey, I didn't come in here with a black triangle. I'm not leaving with one. Fix it. And I said, well, that's wrong, because in those days, we thought rounded emergence profile was bad. This is a long time ago. And then I said, the other thing is I don't have anything. I don't have anything that's curved. It's not my fault. And the guy says, yeah, it is. Make it go away. So if this guy's walking around someplace in Alabama, will you send him back to Tacoma? Because this guy haunts me, right? So anyway, we got a flat piece of Mylar, a wooden wedge. You see the breadcrumb trail. You just don't get where you want to go, right? We got to start with the end in mind, right? And the end is a better shape, right? So this is the problem. And once we developed the Bioclear matrix, I want you to look at this thing. It was a happy accident. I mean, I was just sick of flat Mylar. That's why I invented this thing. But the matrix led to the method. I mean, look at the way that that matrix is fitting under the microscope. It's got a better margin than gold. Now, you have to fit the matrix. You got to understand. You got to heat the flowable. You got to heat the paste. You can't monkey around with it. But you take a look at that and you say, all right, that looks like something that could have an amazing outcome. Let's figure out a method. So then the Bioclear method evolved over the last 15 years to be able to pull off the reconstruction of a tooth with no cutting, with an infinity edge. And so we want to move beyond flat Mylar, and the radiographs on these are unbelievable, except of course, if you make a mistake, they're not great, but if you follow the recipe, if the matrix is right, it should look like this. So the B word, bonding, we don't call this bonding anymore. The word bonding has a bad reputation in the eyes of a lot of dentists and restorative dentists and patients. So we call it the Bioclear method. So let me ask you something, students. The doctor before me tried to close this black triangle with hand spatulation. Didn't turn out so well, right? This is the Bioclear method. And the radiographs at first looked weird to me, right? But when you look at those radiographs, what kind of flower does that look like? So let's open up the mic open up the questions. When I first saw these x-rays, I was kind of horrified. I thought, uh-oh, something's wrong. Because I wasn't used to the shape, right? But then now that I've been doing thousands of these, I love the shape because this is the shape of a solid contact, and it's the shape of a happy patient with good tears, right? When we've gotten rid of all the black triangles. So what flower does this look like? Remember, it's springtime. What flower do these lower teeth look like? The tulip. There you go, Yannick, the tulip. Yes. So one of the interesting things about this tulip shape is it's all about a patient-centered outcome today, right? And you hear a lot of that in medicine. When you treat a black triangle and it has a point contact like those teeth, a point contact after Invisalign is very unstable. And the retainer goes in, the teeth get straight, the retainer goes out, the teeth cross over. I had a huge black triangle. My teeth have been injection overmolded. Point contacts are unstable. You take a look at those bottom teeth, and the contacts are extremely broad. So they're orthodontically stable. And when periodontists and orthodontists look at these really broad contacts, they're so happy because the mobility goes down, the food impaction goes down. So we've got a bunch of questions. So let me back up to the twins. The twins, we treated from canine to canine. So we treated 3 to 3. We want to back up and show that? Oh, it looks like we're backing up. Okay. Back up, back up, back up. Yep. So go ahead, go forward. So on the canines, on the twins, we treated from canine to canine. All right. We injection overmolded, and because the incisal edges were maintained on the canines, I didn't have to do as much volume on the canines. On the centrals, we did lengthen those, and we'll talk about the thickness requirements of restoring an incisal edge. But with the twins, we injection overmolded completely, the canine to canine, and 99% of these teeth is composite. These teeth were so undersized that we actually completely ensconced the tooth when we call WST, whole stinking tooth, right? The only thing that's not composite on these teeth on the outside is her centric stops on the inside. All the protrusion is on composite, and then when she goes into, when they go into crossover, they're on their natural enamel. Except the canines, except the laterals and centrals, we have 1.5 millimeters of length there. So to answer the question, we did canine to canine on both of the twins. All right, sorry that we kind of pushed past that. All right, let's go. So Raphael, did we get that question answered? Yep. Okay. So the Bioclear method, and then we got to get rolling here. The Bioclear method is this. Number one, we have to disclose and blast. Because we're not cutting the tooth, the teeth are covered with both biofilm and a protein pellicle, and that has to be removed because phosphoric acid does not remove biofilm. These teeth, you just can't acid etch them straight when they come into the clinic. We've got to remove this pellicle on the tooth. The next thing is we have to have modern cavity preparations. And these preparations in no way resemble the preparations we've been cutting for the last 150 years because we don't use amalgam anymore in these preps. If you're cutting an amalgam, cut an amalgam prep, okay? But most of us are not using amalgam. The next thing are the matrices. These are not sectional matrices. These are anatomic tooth forms. One goes on the mesial, one goes on the distal. The Bioclear, the twin ring, and the diamond wedges allow the composite to come out like this. So all the wedges and all the matrices have always been built for a margin. Well, with Bioclear, there's no more margin. It's an infinity edge. That's the beauty of it. So the matrix has to sit off the tooth, which is at first is a little disconcerting for, I think, old dentists like me. But for young dentists, like, oh yeah, that makes sense, right? Then we have injection molded heated composites. So 3M has done exhaustive studies, took about a year and a half, and heating of both the flowable and paste in both the Filtech Supreme Ultra and the Filtech One, the bulk fill, it's very safe to heat. In fact, the Filtech One, they showed it in North Carolina, actually gets a little bit stronger when you heat it. So all of the 3M composites have been proven absolutely safe to heat, safe to the patient, safe to the composite. And then the Rockstar polish. So with the Mylar finish is perfect, but then there's like an umbilical cord. We'll go over that. You have to chop through, disc, and marry to the Mylar finish. And that's the challenge because you are going to have to do some finishing, and we want to make sure that it's prescriptive and easy to do. All right, so we got to get going here. I'm going to run through this case very quickly. This is an orthodontist who was self-referred. Unfortunately, the orthodontist wife, she's the wife of an orthodontist. Like I said, she was referred to one of her orthodontist referring dentists, and he said, do the peg lateral. Kind of like the orthodontist said, do some bonding on the pegs. He did some bonding on her peg lateral. And so I'm going to show this. Now the mirror's got this turned around. So this is the wife of an orthodontist. You see she has other problems, which he did not talk about. He said, oh, the orthodontist told me to treat his wife, treat the peg lateral, right? So he treated just the peg lateral. So when he got done, poor guy, this was only about 2 months ago. When he got done treating the peg lateral, he closed the space. With flat mylar, he was super happy because he did close the space on the mesial of the lateral, right? So when he got done, he handed the mirror to the orthodontist wife, and the wife of the orthodontist handed the mirror back and said, I don't like it. It's the wrong blank. So here he is all excited. He closed the space, did exactly what he was told by the orthodontist, closed the space, and he was excited. And the patient says, I don't like it. It's the wrong blank. So students, what do you think she said? It's the wrong what? Amazing. Mona, shape. Sarah, shape. Yannick, shape. Adele, shape. Hugo, shape. You know what happens when I ask normal dentists what she said? Normal dentists say it was the wrong color, right? Or it's the wrong size. It is the wrong size. But a patient doesn't know that a lateral incisor is supposed to be smaller than a central. All she knows intuitively it's the wrong shape. And so we're going to talk about how to blend the composite so you never see a margin. But let me ask you something, students. If you, okay, so we're not, the dentist who did the peg lateral for $200 doesn't get to do the case. And let me tell you about this case. This is a big case, okay? I mean, there are 14 black triangles here, and we charge, you know, around $900 to $1,000 per black triangle. I'm going to correct the midline. I'm going to add to the incisal edge. She's been through orthodontics 3 times. So she's not going to go through ortho again. So I have to fix everything left over here. It's a massive case, okay? In the tens of thousands of dollars. The dentist who tried to do her a favor doesn't get to do the case. Because number one, he didn't approach it comprehensively. He didn't parent the case. He didn't just, he had to stop and say, hey, time out. You have other problems here, really? So we're going to ask you again, if you are going to change the shape of this tooth, of course, if you're going to do it now with Bioclear method, you're going to do a lot more teeth than one. Do you need to change the emergence profile supragingivally like he did, equigingivally, or subgingivally? If you want to change this tooth on the mesial, does this shape need to change supragingival, equigingival, or subgingival to truly transform the tooth? Wow, subgingival. Chris is over here. These kids are smart. Yeah, they are smart. These kids give you a run for the money, don't they, Agosto? Yeah, smart kids, right? Anyway, yeah, we got to change it subgingivally. How do you change emergence profile subgingivally with composite? You need curved mylar. You need the Bioclear matrix. So we're going to go through that. All right. So let's go ahead and we're going to go to exercise 1. So what we're going to do is, okay, now who wants to restore this with flat mylar and a wooden wedge? Any volunteers? Nate? So we're going to go through the deep class 3, and we're going to combine that with a black triangle. Now, one of the things we're going to talk about next week is deep margin acquisition. Deep margin acquisition along with selective caries retention. We pack cords sometimes, but we pull the cord out. This is an old slide from a friend of mine. You take the cord out because if you leave it in, it's going to get stuck there. You're going to be pulling fibers out forever, right? So we're going to combine deep class 3 with the A102. Remember the O2 matrix. This is now in what's called HD. We want you to get familiar with the new HD material. It's 3 times easier to work with. So here's the A102. Once again, it's got the overall curvature. It does not have a lot of emergence profile. And then we're going to combine that with the new black triangle matrix. It's prescriptive for black triangles. And so let me get Taras up here. Taras, are we ready to go? Where's Taras? Okay.
Yeah, we're all ready to go.
We're ready to go. So we're going to switch to the microscope feed. And so Taras had asked us to keep it simple. So we're going to treat a deep class 3 and a black triangle. And while we're at it, let's go ahead and replace the incisal edge. Is that okay, Taras?
Yeah, let's go. Yeah, we wanted to definitely see the black triangle injection molded, David.
And while we're at it, we're just going to do the incisal edge because it's free money. Okay.
Sounds good.
All right. So what's that? Stop share. So as we go along, please ask questions for our expert panelists. And so what we're going to be doing is kind of combining a lot of principles at the same time since we have a limited time together. So what I'm showing you is the exercise that we're going to do. We're going to do a deep class 3. We're going to do big old black triangle. There's a big old spitting hole. And then I'm going to chop the incisal edge down a little bit just for fun so we can go over incisal edge design. All right. So that's the case for the day. Now, right now in dentistry, we see a lot of focus on these omnichromatic materials. So let me show you what's wrong with sort of some of this thinking is if we have a classic cavity prep with a sort of an abrupt margin, this is the kind of stuff, this is an extreme example of using one of these super translucent omnichromatic materials. Now, if there's tooth behind it, that's fine. But if you have unsupported tooth, you're going to get in trouble. And so this is a combination of using a composite that's too translucent. They didn't do what's called additive dentistry, and they didn't do what's called a radius bevel. So let me go over this. There are 3 ways to have easy aesthetics. Number one, additive dentistry. Put a little fullness on the tooth. Number two, a radius bevel. We're going to show you how to do a gradual transition from thick to thin. And then number three, we need to use a material that has more opacity. That's why Filtech Supreme Ultra is our go-to material. It has a nice blend of translucency and opacity. So there's this sort of old school. And then here's a tooth that I did where I did two of the three. I used Filtech Supreme Ultra, body shade, and I did additive dentistry. I added a 0.5 millimeter fullness, but can you see the change in color here? What I didn't do on this tooth was to do what's called a radius bevel. So Dr. Taras, Dr. Drummond, can you see that there's just a little darkness here?
Yep.
Okay. So the one thing that was missing was the radius bevel. So this is one of these that we did for one of these hands-on classes the other day, where I did the radius bevel, and now it's the same composite, it's the same tooth. You can't see the change there. So the three components of being able to injection overmold the tooth and always blend the material, you're never going to match. You're never going to match. We just want to blend. So let's make sure we understand what those three components are. Let's actually have the students, what were the three ways that we get aesthetic blending, right? What are our little Venn diagram? Okay, so first thing we're going to do is a radius bevel. And if we're having any problems, please holler at me. Let me know if you can't see or hear. So let's say that this patient just took a brick to the face too, okay? So we're going to go ahead and restore the incisal edge on this thing. Okay, well, that's a pretty big hole. All right, so let's go back to the slide presentation for just a minute. Do we have the X equals Y on that? I don't think we actually do on that. So let me go ahead and just write this here. The radius bevel is X equals Y. So if we have unsupported tooth structure, like this is 3 millimeters wide, the radius bevel needs to be 3 millimeters wide. And if I'm going to do a structural bevel here for incisal edge, that has to be 3 millimeters wide, so, or 4 millimeters wide. So it's the amount of missing tooth structure. So my radius bevel would actually have to be over here to get blending. And then my radius bevel on an incisal edge would have to be 4 millimeters here because I'm missing 4 millimeters here. So on the palatal, let me ask the students, this would just be a normal bevel here, but do you think that we would need an aggressive radius bevel on the palatal for strength to restore a broken incisal edge? I want a 4 millimeter radius bevel here. How wide would my radius bevel be on the palatal to be able to get structural blending there? So let's open up the Q&A. Let's open up the chat, okay? So it's X equals Y. If I've got 4 millimeters of missing tooth structure, how wide should my bevel be on the palatal? I'm missing 4 millimeters of tooth structure on the incisal. X equals Y. So on the palatal, it should be 4. Thank you. Yes, 4 millimeters. So my radius bevel looks like this. Now this is not a aesthetic or structural bevel there on the class 3 on the lingual. So that's just a normal sort of 0.5 millimeter bevel. So let's go ahead and do the radius bevel. And I know that the students are saying, this tooth is really broken down, put a crown on it. Let me tell you, on a young patient especially, and we have some pediatric dentists that we're working with, it's one of the last things we want to do is put a crown on a young patient. Let me tell you, folks. So there's 2 ways to cut this radius bevel. So this is this great little burr block by Comet. And so the burr that I'm going to be starting with for teaching especially is this burr number 2 in the burr block that they put together. So what I'm going to do here is I'm going to show you how to cut a radius bevel. And the radius bevel becomes tangential to both the disparate angles. So I've got to become parallel to the facial surface, and I've got to be parallel to the incisal. So that is tangential, all right? The same thing here. Once again, 4 millimeters on the lingual for structural blending. Yes?
why would it be an aesthetic radius bevel on the window?
Now, we have a structural bevel here on where the incisal edge is broken. But on the class 3 area, this is not an aesthetic area and it's not really structural. So this area here is just a standard bevel. That's the only place that we still do standard bevels. But if I have to do aesthetic blending on the facial, I need a radius bevel here. And for an incisal edge, it has to be a structural and an aesthetic bevel. And on the palatal, this is simply a structural bevel. Now that burr works great, but sometimes I can't reach everything. And so I'll use my coarse flame burr. This is burr number 3 in the Comet burr block. So I'm eliminating what are called stress risers. So I want to become tangential to both surfaces. I'm tangential to the facial. I'm tangential to the incisal. And the way that you test for this in the clinic is you would take an explorer across both of those intersections to make sure that we don't have any stress risers. So explorer, please. So you would take your explorer from here to here, and there should be no interruption in the explorer. So that's how you create a radius bevel. It's tangential to both surfaces. All right, so the next thing that we're going to do is we have to sand the contacts. So we like to use one of these true contact sanders. That actually allows the rubber dam to go in without tearing. Now, a lot of you think that rubber dams are old school. Hey, rubber dams are cool and sexy again, because with the injection overmolding, it makes it so much easier. So this goes in before the rubber dam so that the rubber dam doesn't tear. And then I'm going to go ahead and bring the single side sander in, because in today's case, we're going to injection overmold these 2 teeth here. All right. And then because I'm going to be back to back on these teeth, I'm going to go ahead and use the double-sided sander so that we have a lightened contact. We don't open the contact, but this is key to the Bioclear method. This is absolutely key. You have to lighten the contact. All right. Now, we normally don't grind on teeth, but these plastic teeth are very shiny. And since I can't blast them, I'm just going to take the glaze off of the tooth. Once again, I would not do this clinically. This is just because the dentiform tooth is so shiny, the composite will not stick to it. All right, now the last thing I've got to do is eliminate these little stress risers here. So I've just got to round this like so, because that will create a stress riser in the composite and potential fracturing. So those have to be smooth because that is a stress riser in the composite. All right. So what we're going to be doing is, this is the black triangle gauge. And so the gauge is used when you insert it facialingually. So it's basically telling me I need a blue matrix when I insert it from the facial, but you always insert it from the palatal because the palatal is typically more constricted because of the arch form. So take your black triangle gauge, bring it in from the lingual, and that looks like somewhere around green. Now, let's say this patient said, I want my black triangle to go away. So in this case, I could use either green or blue. Today, I'm going to use blue. So let me go ahead and try these matrices in. So your matrix is basically your diagnostic wax up. So we're going to slide the matrix in. And because the matrix is so curvaceous, you really want to bring it in at about a 45 degree. If you bring them in straight, you can damage the matrix. Once you've done that, you won't have as good a margin. So roll it in at 45 degree. And then let's bring the other blue in. I can pull them apart if you want. You get it? Yep. Now, this is just a trick on the dentiform, but we typically, the edges need to line up, and sometimes in the dentiform it fights you. So if you're doing this on the dentiform at the school, you need to make sure that the edges of the matrices have lined up completely. So those are edge to edge there. So if one is up like that, that's a problem. So only on a dentiform, we have to kind of scooch them together. That black triangle has been pretty much eliminated. In the mouth, the gum tissue will creep in there. It's like a water balloon. But on adenoform, they're rubber gums. Always check from the lingual, because the lingual will have more tension because of the arch form. All right. And so we're going to be combining two different techniques, really. On the distal, I'm going to use the A102 matrix. Can I just see it the way it comes in the kit? So I'm going to use the A102 matrix, and I'm going to use the HD version. So there's the 1, 2, 3, A102. And this matrix has a little tab on it, and hang on to the extra one for me, okay? And then I'm going to go ahead and place this matrix in here. Now, what if, see, I got these two matrices in here. What if my matrix doesn't insert? What if it's fighting me? The number one reason you have an overhang with Bioclear is that the matrix is not fully seated. So students, if my matrix doesn't seat, what should I do? Quit, go home, do a crown? No. Students, what should I do if this third matrix won't go in? Use the sander. Adele, is that Adele? I got to put my glasses on. Yep. Use the sander. I like to clean up the contact. One of the things that these sanders do is it actually does remove biofilm at the contact. So I'm going to sand this again to give it a long gliding contact, right? Kind of like a guide plane in a partial denture. It needs a long guide plane. So now I'm going to reinsert the A102, and you need to slide this all the way to the attachment. This needs to go 2 millimeters subgingivally. That's an amazing aquarium. And let me tell you something. I am the world's biggest nerd. I use a microscope every day. It's cool. But if I hadn't had a microscope, I would have never known how amazing these things can fit, right? So this is our aquarium. We're going to injection mold this tooth. Then we're going to come back in a minute and do the 2-1, number 9. This is the aquarium matrix, and this is the shield matrix. So students, what do you think the purpose of the shield matrix would be? Now, that's a non-active matrix. It's just sitting there next to this. But I'm about to injection mold. So what 2 or 3 things would putting a shield matrix on a tooth that you're going to restore in a minute? Remember, we disclosed and blasted and removed biofilm from these teeth, and now we're going to acid etch this tooth. So what would the shield matrix do on the neighboring tooth that I'm going to restore next? So Emily says, wouldn't a crown be better? And the answer is no, it would not, okay? And that's a lot that you need to understand, because Emily, you have a bias that crowns are better. When we look at the biomechanics, it's very hard on a tooth. You put a crown, it can snap off 10 years later, and then you got nothing. So Emily, that's a great question. That's a bias that we have as old dentists, right? Okay, so students, what is this shield matrix doing for me when I injection mold this? What do you think? What benefit do you think the shield matrix is going to provide? Somebody give me a guess. We're going to injection mold the 1-1, number 8, and I've got this matrix sitting here on the neighboring tooth just until I do the next tooth. Does anybody have a guess? Support, very good. Prevent acid etching, yes, 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 yes. All those are correct. These are. Can everyone see those answers? Can everyone see those, Carissa? Can everyone see everybody else's comments?
No, only the panelists can.
Only the panelists can?
If they change their to all panelists and attendees, then everyone can see it.
Okay, can you send them that message? You can, Carissa's gonna send something that you can see everyone else's comments, but let me read through them. Abdullah says support. Adele says prevent acid etching of the neighboring tooth. Mansi says so 11 doesn't become over contoured, the 1-1. Yannick says protection. Andy says protecting the tooth and maintaining the shape. Yes, Andy, yes, yes, yes. Sarah says shielding the other tooth, exactly. Provide support. Okay, so this is the shield matrix. It's going to maintain the shape because when I injection mold the 1-1, it's going to swell. And the number 2 thing is it just keeps all the stuff off the other tooth. logistically, it makes life a lot better. So what we would do clinically is we would etch, rinse, and dry. So we're going to do a total etch. With the Bioclear method, total etching is really mandatory. And so Scotch Bond Universal allows us to do a total etch. And then let's imagine that we've acid etched, rinsed, and dried. And so now we're going to go ahead and, Tanya, if I can have a large scrubby, we're going to massage the Scotch Bond Universal into dentin tubules for a full 20 seconds.
You want the large?
Yep. So I'm going to pull the matrix open, and we're going to massage the adhesive into dentin tubules for a full 20 seconds. And how do you know it's been 20 seconds? It's cumpleaños feliz, te deseamos a ti, twice. 20 seconds is forever. And in French, it's benefit, I forgot. We did that yesterday with Montreal. No, with Montreal. So 20 seconds is forever. And then you're going to massage 20 seconds into dentin tubules. I think the national average is about 6 seconds. It's one of the main reasons we have postoperative sensitivity. So we're going to massage the adhesive into dentin tubules for a full 20 seconds. And then we're going to air thin and cure. Okay, let's see the paddle. So let me show you something. One of the problems, and Richard Price up there at Dalhousie is someone that everyone should listen to. A lot of us are not doing good light curing because we're not using some kind of paddle. Now, the good thing is, now that my kids are back from college, I can spank them when they're bad, right? Because they're all living in my basement. So a lot of us are not doing good light curing because we're going like this with our eyeball. You need to use the paddle. You need to look to make sure you're right on the tooth. If you're half a tooth away, it's not going to work. All right. So now we're going to do injection molding. And so injection molding is 3 phases. Number 1, we're going to splash a bunch of adhesive in there as a surfactant, but not light cure. You have to have the surfactant. Number 2, heated flowable. We're going to be purposeful. We're going to start toward the palatal at 45 degrees and come forward. If you don't do this, you'll block your view. Then number 3, heated paste, because the Filtek Supreme Ultra Paste has incredible shine retention. You saw how shiny these things can be later. You don't want to do just flowable. You need a very shiny material. And so that's the reason that we use Filtek Supreme Ultra. I'm going to put my adhesive in here, and I need this thing soaking wet, okay? Now, I'm a child of the 70s, and back in the 70s, we liked big hair, okay? Now, I'm kind of losing it now, but Nate remembers when I had big hair. So anyway, I'm going to splash. I'm going to have one more with wet adhesive. We want to use lots of adhesive in here. So John Bon Jovi had tons of hair and tons of hairspray. So we're all about that. And just so you know, my hair was bigger than John Bon Jovi's. Okay, I just want to clarify that. Okay, I know that's important to all of you. Right? Anyway, lots of hairspray, right? So we're going to air thin this. I want you to watch how this adhesive swirls around. Look at this. If you didn't think the tooth was wet, now it's wet. So now we're going to take the Filtek Supreme Ultra. Make sure your matrices are seated. We're going to inject at 45 degrees, starting at the palatal and displacing the flowable and injecting to an infinity edge. You saw the x-rays. This is how you do it. And then you injection mold through the contact like that to get a beautiful broad contact without stain. Then you're going to inject here, 45 degrees, starting on the palatal so you don't block your view. Okay? And you're going to come up and push it through the contact. And then you're going to come on the lingual and basically fill the lingual. This is where people go, ah! So just get it out of your system. Ah! We're going to use a fair amount of composite. This is a beautiful alternative to a crown, but you got to play by the rules. You have to inject it into the flowable that went around the corner. So let me ask the students right now, what would be wrong with just injecting right here? Why can't I just inject the flowable into an airspace? What would be the problem with injecting into an airspace? I'm going to inject into the flowable that went around the corner, and it's purposeful. And so let's ask the students why we have to inject when we come to the lingual into the flowable that already went around the corner. Next comes the paste. And I'm going to use heated paste. This is Filtech Supreme Ultra Body Shade. And I'm going to press this starting at the cervical. And I'm going to do like a windshield wiper. I'm about 1/2 millimeter off the tooth. You want to be sitting off the tooth so you don't get all this turbulence. You've all heard of phyllo dough, right? Or pie crust. You don't want a bunch of layers here, okay? Now, because I'm restoring an incisal edge, I'm going to pump a whole bunch of hair in here. I'm going to have a big old hairdo today because I'm from the 70s. You want to have enough composite so that it's absolutely monolithic. And I'm going to pump one more in there just to make sure, because I'm on TV today and I don't want to have a problem later, okay? So I'm going to pump in just a little bit more paste. And Chuck Hudson is okay with that. He'll make some more for us, right? Okay, so there we go. I've got at least an extra millimeter for cutback. The next thing we do is we massage the matrix. So let me show you what it looks like from the incisal. Now, can you see, Dr. Robles, can you see that this matrix is distended compared to that one? If you don't massage it back, the line angle is distorted. These matrices are really tightly wrapped. You have to massage it back so it simulates your shield matrix. And so we just do a little bit of massage. We're going to take the umbilical cord and just lift it off there. I've got a little bubble right there. I'll deal with that later. I'm not going to chase it right now. There's my umbilical cord on the facial. I'm going to come in and have my paddle. I'm just going to take the composite away from the gum line, like that. And then the last thing I'll do is we'll take a dry brush, and this removes any composite that's on the wrong side of the matrix. And the same thing here on the lingual. We want to remove any excess. Now, if you're doing any bonded porcelain, this is the same thing you do when you bond a porcelain veneer. You get rid of the extra flowable composite around the margins. And now let's like here. Let's just do it. Go ahead. So we're basically going to cure, go ahead, 10, 10, 10, and 10 seconds. I'm hurrying this up because we don't want to belabor the point. And then 10 seconds, and then 10 seconds. So you want to make sure it takes time to cook these really large restorations like that. So that's it. We're going to go ahead and disassemble. And there's no good way to get you past the shock and awe of injection molding. So I figured I'd just give you some great big tooth and just kind of blow everybody away, because this is so easy to do once you understand the recipe. Now, normally, actually, we should take the shield matrix off first. I got a little, it is 5:30 a.m. on the West Coast, right? Now, you'll notice something right here. And if you're in the lab, instructors, I want you to notice this. Right there, it looks kind of orange. I don't know if you can see that or not, but there's kind of orange there. What that means is that that area was not completely light cured. Now, those are the camphor quinones that are in there, right? Our biomaterials person would know, already knew that, right? Nate already knew that. So it's a big deal. And if you don't completely cure these, they may turn a funny color later. So what we're going to be doing is we're going to be taking this tooth to 80%. So when you're doing a pair of teeth, you need to take the first tooth to 80% because you need a breadcrumb trail to follow. You don't want to get too frightened when you go to the next tooth and it's all piled up too. So what we're going to do is we're going to cut exactly 1 millimeter from the incisal edge, no more, no less. It's one clean cut from facial to lingual. That's much safer than mesial to distal. This is something you're all going to have to get used to. All right. So 1 millimeter from the incisal edge. And then on the facial, we're going to be adding 0.5 millimeter, remember? So now I'm going to cut 1.5 millimeters from the enamel on the other tooth. Same thing on the lingual. Remember, don't touch the tooth, don't touch the tooth, don't touch the tooth. Now, this is a neat little bird that we find pretty critical. This is called a Q finisher. It's actually it has the ability to cut and to polish at the same time. So the rule on when we do the lingual is, do not cut the cingulum. Leave that off for a minute. Do not cut the cingulum and do not cut the incisal edge. I want to take the Q finisher in the middle of the lingual to create a fossa here. All right? So once you see the tooth underneath, then we stop. Then we're going to go to the Softflex XT disc. So we want to be very purposeful with our incisal edges, that the negative space on the incisal edge really matters. So what we're going to do is we're going to bring the Softflex XT disc course tipped about 15 to the palatal, not to the facial, 15 to the palatal. Suction. So I'll be coming about this angle. I'm going to take it within about a 0.5 millimeter of the neighboring tooth and stop, because we're going to disc the incisal edges together in a minute. Then we invert the disc. We start on the incisal third, where there's a lot more excess, and then we slow down to turn the suction off. We'll slow down, and we go to the gingival half. We want to maintain some of that mylar finish. We do our little bumpers here. So now we're ready to move on to the next tooth. We've taken this to about 80%. And we move on. So there's kind of our block tooth. All right. So the central incisors have to be identical twins. So we're about to injection overmold the next tooth. You can see that the area where we did the disking, the tooth looks a lot less, looks a lot whiter. The value is going to drop once we polish that back. So you'll notice a real difference between the mylar zone and the disking zone. So when we get a really, really bright polish, the value goes down, the translucency goes up. So that's a nice demonstration of that. So we're going to injection overmold the 2-1 or the left central incisors. So we want to be identical twins. So let me ask the students. What matrices would you put on the 2-1, because we got to finish the case? What would you put on the mesial and what would you put on the distal? And if you can't remember the names, just kind of, or would you do just a matrix on the mesial? Would it be smarter to just matrix the mesial of the 2-1 since there's really not much on the distal? What would be smarter? What would be faster? What's that? I didn't, but they remembered that I used a blue black triangle on the mesial, and I used an A102 on the distal. Okay, so can they see each other's things now?
Yes.
Okay. Wow. See, this is great. So Hugo says, same as the previous tooth, they both need to look the same. Exactly. If you don't put a matrix on the distal, they're not going to be identical twins. So Adele says, putting matrices on both mesial and distal for symmetry. Exactly. Matrix on both to keep everything contained. Parker, awesome. Parker Allison, awesome. Yes. Actually putting an aquarium on there to keep everything contained creates thixotropic flow. It's just easier. So if you got a little class 3, that's fine. But once you get to a certain point, having an aquarium is super duper helpful. Okay. So we've got a question about what we do with the dentin versus enamel. So we'll go over that again. So let's go ahead and get the matrices on. So we've got the black triangle matrix on the mesial, the A102 on the distal. Once again, if my matrix doesn't go in, we know what to do to sand it, but my sanding there was okay. Now, I don't need to put a shield matrix on this tooth. In fact, I don't want to put a shield matrix on this tooth because the shape is already maintained, and I don't want to put a matrix on here, a shield, because it might have more of a less of a tight contact. So just because we're only doing the 2 central incisors, I'm not going to put a shield over here or over here. We only put shield matrices on the tooth that we're going to restore next, right? So we're going to etch, rinse, and dry. And then I don't have any, I really don't have any freshly cut dent and tubules on this tooth. So because I don't have any freshly cut dent and tubules, I don't need to cure the adhesive independently. Now over here, I had lots of freshly cut dent and tubules. I had to cure the adhesive independently over the dentin, and then we use the adhesive secondarily as a surfactant. So once again, over here, I massage the Scotch Bond Universal into the dent and tubulars for 20 seconds, full 20 seconds, air thinned and cured, and then injection molded. I don't have any freshly cut dentin over here. So I don't need to cure the adhesive independently over here because this is basically all enamel. So let's go over with the students. Let's have them answer. I'm about to injection mold. I disclosed and blasted. I did a total etch, rinse, and dry. What is my sequence for injection molding? There's 3 components to injection molding. So let me hear it, students. We're about to injection mold. We don't need to cure the adhesive independently over the dentin. So what is the sequence for injection molding? What's next? Okay, we got a perfect answer here. I'll wait for a couple more. But I want all 3 steps. What's first, what's second, what's third? I gotta have one more answer. Come on, students. There we go. So we've got Parker and Mancy and Bumika. So yes, we want adhesive as a surfactant, air thin but not light cure, flowable, and then when we inject the flowable, you can pipe in and tell me how do we inject the flowable. So we know how to do the adhesive. Tell me how my purposeful injecting is with my flowable. Where do I start? How do I inject the flowable? Tell me that, okay? So we're gonna massage the Scotch Bond Universal into the, now we do have a little bit of dentin tubules here, so this is kind of a cheat. We're gonna massage here because there's just a tiny bit of dentin, but because it's a microscopic amount of dentin on a black triangle, we're not gonna cure it independently, just like with a porcelain veneer. Okay, more adhesive, please. And we're gonna wet it in here. And let me have a little bit more adhesive just to make sure. All right, so I'm waiting for the students to answer. When I get to the flowable part, what is my strategy with the flowable? Where do I want to start and how do I want to inject my heated flowable? 45 degrees from palatal to buccal. All right, Hugo, there you go. Perfect. One of the questions was, will the students who have to run off and do something be able to watch this? Yes, the video will be recorded. You will get a link. Okay, so we're going to injection mold, just like the student said, 45 degrees, starting at the palatal so we don't block our view. Inject slowly, let the flowable go around the corner, cover the contact. Now the distal is harder to access because it's little. Big caries and big black triangles are actually easier. All right. And then we're going to come on the lingual and we're going to injection mold here. And we're going to injection mold into the flowable so that we don't trap an air bubble. You students were right. That's exactly why. You do not want to inject into an airspace. You will trap a bubble. Now this is a smaller black, there's no class 3 here, no incisal edge. I'm going to use about 3/4 of a compule here just to veneer over the tooth to push the flowable up toward the top. Paddle goes here. Once again, my reference tooth is going to dictate, white please. My reference tooth here is going to dictate, is my matrix distended? And it is. If I don't massage that back, the line angle is going to be distorted, okay? So let's massage that back, massage. We'll scoop it out of the gingival here, but leave the umbilical cord elsewhere. Dry brush, please. What's the purpose of the dry brush, students? What's the purpose of the dry brush? Let's see what the purpose of the dry brush is. Are we getting answers? What is the purpose of the dry brush?
Removing excess to remove composite that is outside the matrix.
Bingo.
Excess the matrix, moving excess composite, remove flash.
All of you are correct. Perfect.
Clean away from gingiva.
Bingo. Okay, paddle, please. So we want to do 10 seconds, 10 seconds, 10 seconds, 10 seconds. I'm cheating here because, you know, we got to get going. But I would never cheat clinically. Okay. All right. So it's important to have one of these, a robust explorer to disassemble. We'd like for the schools to have some of these Clark Explorers and a few of these instruments so that you can really manage the matrix more effectively. A flimsy explorer here, I'm telling you, is just a nightmare. You want a very thick shafted explorer. Okay, and hemostat, please. Now on these dentiforms, sometimes you don't get a tight contact. You students know this. You have to wiggle the teeth because you don't have a periodontal ligament, right? Okay. All right, students, we have to do our cutback. So let me ask the students, we're going to go to this. Hang on a minute. We're going to go to the burr number 3, which is the coarse flame. These are coarse diamond. So tell me about the initial cut. How do I cut and where do I cut first? All right. We're going to take this tooth to 80% and then do them together so that they're identical twins. So students, where do I cut first and what are the rules? Incisal edge, okay? Where do I cut? How do I cut? Is it facial to lingual or mesial to distal? And how close do I cut to the neighboring reference tooth?
Facial to palatal.
Facial to palatal,
Facial lingual.
leaving 1 millimeter from the adjacent tooth. Thank you, Mahya, M-A-H-Y-A. Yep,
Maya.
Maya. Okay, good, thank you. All right, 1 millimeter, go ahead. Okay. Now on the facial, how close did I cut to the facial enamel? On the facial, how close did I cut to the facial enamel? Let's see what they say. What's that?
Everybody says match other tooth.
We want to cut 1.5 millimeters from the facial because we're going to lose some volume with our disc. So we actually cut 1.5 millimeters on the facial from the enamel because remember, we're adding 0.5 millimeter of additive so that we have better aesthetics and better blending. And we only do the middle of the tooth, not the cingulum, not the incisal edge. All right, so then let me ask, what instrument is next? Where do we start and at what angle? All right, what instrument is next to sculpt this tooth to take it to 80%? Disc, coarse disc. Okay, where do we start and at what angle? Where do we start? 15 degrees to the palatal. Thank you. Okay, coarse disc, 15 degrees to the palatal, approximately, right? So we're going to come in here, not here. You never want to see the incisal edge, right? You would never cut it like this. All right, go. And I'll let one of our panelists explain. Why the palatal edge should be cut at 15 degrees to the palatal, not the reverse. So I'll let some of our faculty explain why it is that that should be at a 15 degree-ish.
Robles, that sounds like all you, right?
What's that?
I was volunteering a Robles dancer. Is it
Question?
I don't know if it's an aesthetic or an occlusion thing, to be honest.
Both, right? I mean, because the incisors wear tip to the palatal, and then the lower incisors over time wear tip to the facial, right? That's because of the inclination of the teeth. So the mistake that people make is that the incisal edge they think is sort of flat to the face, and it's not. It has to be tipped to the palatal. Partly because the tooth is tipped facially, right? Okay. So Nate, I would say both on that, right? It's both for aesthetics and for function.
Yeah.
Yep, good one. Okay. So now we're going to go ahead and disc the two teeth together. We're going to disc for symmetry and efficiency. So I'm going to put the disc on both teeth, roll the incisal edge in, and then roll in the distal, and then slowly come along the gingival, like so. Bring my little bumpers in here. And I'm not going to spend a lot more time sculpting because we need to move on. Now, a couple of things that we really want to emphasize that are new for some of our instructors is the one place where these restorations can bother the patient is if they're too full in the incisal third. And so I want to take the disc at 45 degrees along the facial to put that bevel right there to tuck the incisal edge in. If you don't do this, the patient's going to complain about fullness and phonetics when they're speaking, right? So I'm going to bring the incisal edge. We're just going to bevel that in a little bit. And then the same thing on the lingual. And so my residual incisal edge is only about 1 millimeter thick. I'm going to leave the powder there, don't blow it. You see the powder is, the incisal edge is only about 1 millimeter thick, but that's because we've gone in and created this sort of bevel, and that helps when they go into protrusive and crossover. And then the last thing I'll do is I'll take my disc, now that it's kind of worn out, and we'll just round those incisal embrasures. This disc is very worn out now. It's a coarse disc, but it's actually almost fine. And then we'll do the same thing over here. The teeth have to be identical twins. Let's grab the smile design gauge and let's see what the students think. Am I identical twins? Let's take a look. So we started at 8.5. Let's see if that is going to satisfy. So students, are these identical twins, or is one tooth looking a little bit wider than the other? What does everybody think? Is there one tooth that looks wider than another, or are they identical twins? What do you think? Taras, students, what do you think? Am I okay?
I'd say that's looking pretty good.
Yeah. That is really, really close. Yeah. The 2-1 might look, no. Close enough. Okay. All right. So now we're going to go to the Rockstar polish. It is 7:15. I'm going to spend about 5 minutes doing this. We have a brand new Rockstar polish video that Dr. Charlie Regalado put together for us. So we'll send the new Rockstar polish soon, right, Carissa? Mm-hmm. We're just days away from that Rockstar polish video. So what we're going to do is start with what's called Magic Mix. And so the Magic Mix comes in this sort of pate. We put some here, and then we use a disposable cup like so. And we're going to do this at about medium speed, sort of pulsing here. I'm going to pick up fresh Magic Mix every few seconds like this. Pick it up here.
You're going to want your cup.
Yeah. And it does a nice job of rounding all of the contours. Patients can feel any little sharp areas with their tongue. And then that's it. And now we're going to go to the Rockstar Polisher. We want to use the Rockstar Polisher dry for a moment because it's a lot more aggressive. It's diamond impregnated. All right, let me have the RSP, please. So we want this finish to look like etched enamel. It should not have any unidirectional scratches. All the scratches should be omnidirectional. And so the polishing of composite is something that historically has not gone very well for us. And it's funny, 3M supported some research up at Dalhousie, which we need to get published. This Rockstar polish had a higher shine than anything that they'd seen before. So let me have, go ahead and we're gonna do this dry for just a minute. Now you can lay the cup on its side and it's pretty aggressive for polishing. And I'm just gonna focus on one tooth here so I can get it done. You can see that I've got a little bit of a problem right there. Instead of backing up, I'm just gonna use the side of the cup with pressure. And that's why we use this dry, because I can see what I'm doing to get rid of any of the deep scratches. And then I'm using light pressure here dry. And now let's go wet, please. Air, water, about an inch away, good. Now I'm using heavy pressure. Keep water coming back up, further away. And so we'll stop here. It's not perfect, but, and I left a little bit of pink from my magic marker. And I've got a little tiny void here, which I'm trying to polish out, which should never happen, but of course it happens today. And stop. All right. So I'm just going to put my thumb right there to hide that spot. Is that okay? So that's the Rockstar polish. And that's kind of the quick version of that. And so let's go ahead and take any quick questions before we go to the injection molded class 2. And so you can see just a little bit of the show through. And these dentiform teeth are incredibly, challenging to hide because they're like TB1, toilet bowl white. But that is the concept. So let's see if folks have any questions, or if the faculty has any questions about anything that we've done so far.
Everyone is saying that the T1 looks slightly wider.
Whiter or wider?
Wider.
Oh, I think they were right. I think the 2-1 looked a little bit, yeah, these students are kind of picky, aren't they? I think the 2-1 was just a little bit wider. That's the value of that smile design gauge. So we could have brought the 2-1 in just a little bit. Good for you. Yeah, you're tough on me today. Okay, any other thoughts or questions?
David, the question that I often get is, are we injecting the paste on the buccal and the lingual?
So the answer is not anymore. And the paste does such a beautiful job of pushing the flowable up. It's extremely difficult to injection mold from the palatal because of access. And we see mistakes and the matrix moving around. So because of the thixotropic flow, we're able to get really good movement of the flowable up and out. It's okay to have a little bit of flowable on the palatal. The Filtech Supreme Ultra Flowable is 90% as filled as the paste. It's not like it's junk. So having a little bit of flowable here and there on the palatal does not change the overall integrity of the restoration. So we no longer inject from the palatal. Awesome question. I'm so glad you asked.
Thank you.
Wedging versus not wedging.
When do we wedge versus not wedge? I'm going to let Dr. Bustamante. Let's see if Dr. Bustamante is awake, or anybody.
I am here. I am here.
When do we wedge in the anterior? When do we not wedge in the anterior?
I generally do not wedge in the anterior if I have a nice contact. I don't need a wedge because my matrices and the contact will be enough. If I need to wedge, it's because I do not have a contact and I need to recreate it.
Right. So in this case, even though the tooth was completely blown out, Nate, and here's the cool thing about the whole new algorithm, and Dr. Robles here. Here's the thing. the new algorithm for treatment planning. When you looked at that busted down tooth, it had that huge black triangle, big old class 3, incisal edge was gone. When I look at it with my Bioclear eyes, like Raphael's saying, do I have a contact, even the little tiny contact? If I do, what happens? The matrix seats perfectly. The gingival margin gets closed. So we can fix some pretty broken down teeth easily if they have a contact. And that goes back to that question that the dental student asked, when do you use a wedge? We had on all of our black triangles or any of these class 3s where the contact is intact, you don't need a wedge. The HD is so stiff and so strong, you are not going to get an overhang. So that's how Bioclear changes the treatment planning. So let's take a look here and see how I did today. Now the lingual doesn't count because that's got a 14 millimeter periodontal pocket, right? But I want you to take a look here at the gingival margin. And when you slide your Explorer across this, you can't even, I got a nice little black hair in there. I'll charge the patient extra for that, right? You can't even feel that margin right there. Now this little egg-shaped contact, we actually want that. Look at the margin here. It's literally not there. So that's the miracle of injection molding when you use the proper adhesive as a surfactant. I mean, this blows people away. Look at my void today. Boy, I'm not going to start any classes before 6 a.m. ever again. This is a non-structural bubble. Okay. So that's what blows everybody away. And the thing that I want you all to do in your schools, Nate, Augusto, let them do this. Pull that out of the dentiform. Take the Explorer across there. And if it's not perfect, they messed up, right?
In all honesty, that was the most impressive thing when I tried this the first time.
Yes, and you have
blown away by it.
You have to do it with your own hands. I was as surprised as anybody else that it was that good, right? Now, if the matrix isn't fully seated, or if it's the wrong shape, or you make a mistake in those 8 little steps, then it's not going to look like that. Bioclear is really simple, a bunch of little simple steps, but you got to follow them, right?
What was the what did you use to apply the polishing paste? The first polishing paste.
You have the Magic Mix kit. Okay, so the Rockstar polishing kit comes like this. And so we've got all this great schools pricing if you ever want to get this stuff. But basically, the way it works is this. The Magic Mix comes in this great big tub. This lasts forever. And at Roseman, they just put out a little dollop in a dapping dish for the students. And then it comes with disposable prophy cups. So these are just little cheap disposable prophy cups, okay? Metal shanked prophy cups. Where is that thing? Yeah, here it is. So it's this little disposable cup that comes with the kit. And then the second step is the diamond impregnated polisher. These are autoclavable. You can use them up to 20 times. These are, not free. So these have to be autoclaved and reused for the final step. The reason that we want the Magic Mix and the disposable cup is we're not doing fillings anymore. We're shrink wrapping the whole tooth. We've got to be able to flange that cup over the incisal edge, into the embrasures, subgingivally to get rid of the little goobers of flowable, Nate. And that's got to flange all over the place. I mean, it's kind of like when you go to the lab and you polish a denture with coarse pumice. We need to get total access with a concave surface to take care of that. So Nate, thank you for asking that question, right? The Magic Mix is the slurry of large and small particles of aluminum oxide. Good job, Carissa. And we have to deliver it in a cup that's concave, and we have got to be able to move it around the tooth. Once we've done that, then we want to put that ultra shine on with the Rockstar polisher. We keep it simple so that we use fewer things and we get more out of each thing. Like that soft XT disc course, we only use 1 disc, right?
Yeah. Which
is good for the school because I don't want you to put out 8 discs to a student because they all have to get thrown away, right?
Yeah. And so the paste you're not using with the diamond impregnated polisher. It's
right.
It's the first step, and then okay.
Yeah, 2 different cups. And thank you for asking because everybody asked that.
Oh.
The way that I like to do these presentations is to kind of throw it out there and then let you kind of digest it and then ask. So Nate, by you asking that, it's a lot more, it's a lot better learning than me just yakety yakking. So I appreciate you helping to teach the class today.
Oh, that's because I think that that's like one of the really impressive things is to look at that polish, and it's crazy that we just saw you put it on there so fast, because it's, I mean, it is a really nice polish.
Now, one of the things we have to remind ourselves is you could put makeup on a pig, but it's still a pig. That's how we talk in Tacoma, right? So if the composite's chalky and hand manipulated and has gaps and voids, you can put makeup on a pig, but it's still a pig. So one of the things that makes the polish special is the fact that it's monolithic, and even that one little tiny bubble you saw would betray you, right? So hand manipulation is never ever going to look like this.
Yeah.
Ever. Yeah. Great points, everybody. So let's see here. So what we're going to do now is we've got about 5 or 10 minutes. We're going to jump in and do an injection molded class 2 because I promised Taras that we would do that. So let's just jump right in. We'll send you all of the materials, all the supporting materials for this.
Okay.
Taras has already done quite a few lectures on this, but let's just go ahead and jump in and do it. All right.
Thank you.
So we're going to injection mold this class 2. One of the things that I try to always do is to optimize the neighboring contact. It's a big part of getting a great class 2. So I need the lat grip here. Where did it go? So what we'll do is we want to make sure that the neighboring tooth is perfectly groomed. And so just like before we do a crown preparation, I like to make sure, this is one of the things we really harp on at the Learning Center, is we want to make sure that the neighboring tooth has a very nice flat guide plane for a contact. A contact is a relationship, it's a marriage between two teeth. So we want that contact to be basically parallel to the contact area, kind of parallel to the long axis of the tooth, but really most importantly, it can't violate the space. So that's key. Now on the dentiform, we would prefer you to use the Biofit 6.5 matrix because you don't have an attachment on a dentiform. You can tend to get an overhang that you wouldn't get in the mouth. So I'm going to use the Biofit 6.5. Make sure and grab the handle or the tab of the matrix. Now remember when we inserted the black triangle matrix, it had to come in at an angle. Do you remember that? That's because all these Bioclear matrices are curvy. So you got to rotate it in because it's so curvaceous, right? So you rotate that in, and then I want you to make sure that the tab is centered over the marginal ridge of the neighboring tooth. And then you're going to push the tab down as hard as you can. Now this is where nobody gets it. Nobody pushes hard on these matrices because a metal matrix would either cut your finger or smash. This matrix is unsmashable. You have to drive this thing down as hard as you can. And that's the mistake that people make. And next week, we're going to talk about deep margin acquisition, how we pack cord to get the matrix all the way sub G, and talking about using some 9mm matrices to do that, okay? The next thing we're going to do is we're going to bring our diamond wedge in, and the diamond wedge has to come in at a 45 degree. The diamond wedge has to come in at a 45 degree because it comes in like a suture needle. So you bring it in like this. Now the diamond wedges are special because they collapse and then pop open when they come out the other side. So that allows us to get an edge-to-edge infinity edge because this thing has to go from line angle to line angle. So I need an hourglass shape that's going to keep me from getting an overhang here and here. Now, Nate, Dr. Robles, doesn't that drive you nuts to get an overhang right there?
Yes.
It drives you crazy. Now, in the old days, we were supposed to cut the composite off here. You're going to injection mold all the way to here. So we had to build a matrix, and I know you and I, Nate, we're going to talk about this. You need a wedge that actually engages the matrix all the way to the line angle because with the Clark Class 2, we're going all the way to here. So the last thing you do is you'll take your cotton pliers using the flat end, not the point, the flat end, and give it a push because the back end of the wedge is a little bit wider than the front end. And then I'm going to bring my twin ring in, and I like the bicuspid because it's got a little bit more power. You can use, obviously the molar, but the yellow has a little bit more power. And you're gonna basically straddle the wedge, and then let go. And then the last thing we always do is we waggle the separator apically. The twin ring is very different than a normal separator. It only grabs at the gingival. It doesn't clamp it off up on the occlusal because we want an infinity edge. So you got to seat this baby like a rubber dam clamp, okay? Now you'll notice that my contact is open. Probably the number one complaint about posterior composite is the contact. We don't care anymore. Dr. Robles, Nate, Taras, Dr. Drummond, we do not care. That's going to close 100% of the time with the push-pull technique and the push-pull instrument. So we're going to etch, rinse, and dry, and we typically etch to the edge of the matrix. I would acid etch to here, rinse and dry, and then I want to go ahead and use my go, no, go probe. Most of us are still layering, and we need to stop layering. So this is the go, no, go probe, and they have these in the pre-clinic at Roseman. I'm going to measure this, and with Filtech 1, I can cure up to 5 millimeters on the interproximal. That's the 5 millimeter mark. So students, I can fill to 5 millimeters with Filtech 1. This is a 5 millimeter mark. So is this a go or a no-go on the distal? Do I need to layer this, or can I injection mold with one shot because we have a clear matrix that allows 5 millimeters depth of cure? Do I have to layer this, yes or no? That's a 5 millimeter mark. And Filtech 1 will give me a 5 millimeter depth of cure. So is this a go or a no-go? Do I have to layer this one, or can I injection mold without layering? One shot, no layering. All right, good job, students. Now, if you put your go, no-go probe in here and it's in the red, that would be a no-go. And we would have to put a little bit of flowable here, just 1 millimeter down there, cure, and then injection mold. Okay? All right, so we're ready to injection mold. We're going to massage the Scotch Bond Universal into dentin. Okay, students, how long do I have to massage the Scotch Bond Universal into dentin tubules to decrease sensitivity and get a decent bond? All right, how do we know it's been 20 seconds? Sing happy birthday. All right. Okay, you're with me out there. Okay. That's 20 seconds. Happy birthday to you. Now you have a PDF in Spanish. You have a PDF with every step that we sent to you. Okay. Then we're going to do the spot weld. We're going to put a little bit of adhesive on the corner of the matrix and a little bit of adhesive on the corner of the matrix. And then we're going to air thin, but not light cure. And then we're going to do what's called the spot weld push-pull technique. It's critical we all use the same lexicon. And people can be confused because it's new. We call it spot weld push-pull because you spot weld first, push-pull second, okay? We're going to put a little bit of bulk fill flowable on the corner, outside, over, and inside the matrix. And then we put some bulk fill flow outside, over, and inside the matrix. You have to lock the matrix to the tooth. And then we do the push-pull. This is the push-pull. It is a push on the distal and a pull on the mesial. It has two little hands that flange apart, so it self-adapts to pretty much every cavity shape. I'm going to drop this in here and make sure that the hands are parallel to the long axis of the tooth. And then I want you to push hard with two hands, hard. And now that's actually going to make a really tight contact. And now we cure. So go ahead and cure. So she's going to come up. Tanya's going to come up and cure. Go ahead and get the buttons, get there. And get the lingual button. And that's it. Come away. And now we're going to cure. Go ahead. We're going to cure on the interproximal because the instrument didn't allow full depth of cure. So that's 10 seconds. So now we're ready to injection mold. So what are the 3 phases of injection molding? Let's hear it again. It's good to be in the routine. It takes a while to get used to this. Let me have a bender brush. So what are the 3 phases of injection molding now that the dentin tubules are happy? What 3 things happen next? What 3 materials go in? You already answered it. Let's hear it, students. Adhesive, flow, paste. Perfect. You want to push the adhesive around the corner so to get to your infinity edge. If you don't use a surfactant, you are not going to have a happy ending. You will not get there. And so 3M actually did research on this to show that it's okay to what they call co-cure or cure the adhesive, flow, and paste together, just like we've always done for porcelain veneer. You want to inject purposely at 90 degrees to the matrix tooth interface. I'm going to bump my magnification up. I want you to watch this thing flow all the way around the corner. I tell you what, it doesn't take that long to get good at this. We had a 12-year-old girl come to a learning center, to a class I taught on the road one time. A 12-year-old girl beat half of the doctors who had 20-year experience. Why? She followed the rules, and she thought it was fun, right? She followed the rules, and she thought it was fun. All right, paste. Now you want to inject the paste. If you push the air out, that's great. You'll get less air bubbles. So you see that right there? Push the air out. I'm going to injection mold into the flowable. Now it's a little messy today, but I told you, like John Bon Jovi with his big hair, once all the flowable is gone, which it is, you can feel a shift in the viscosity and you pinch it against the tooth and come away. Now I know I got a big old glob right there. I'm just demonstrating. It's usually not this messy, but it doesn't matter. It doesn't matter how much the excess you've got. Whoop, I'll do that. Okay, so now this is new, everybody. It's faster to sculpt than it is to manipulate, and the more you manipulate, the worse things get. Don't remove the excess. I want to leave a lot of excess on both the cusp areas so it shrinks toward the margin. I'm seeing less white lines now that I'm doing that under the microscope, and because we need to train all of us to be able to sculpt rapidly and safely and quit removing excess. With injection molding, it's the opposite of bonding, right? It's the opposite of amalgam. Injection mold, leave the excess, leave it up there at the cusp tip, let it shrink toward that cusp tip. Okay, I'll get rid of this big goober right there, but I'm gonna leave, why? I'm gonna leave the rest of the excess at the cusp tip because I can sculpt it more safely and it's advantageous. So I am gonna make one central groove cure. That central groove reduces finishing, improves depth of cure, and helps to mitigate C factor. So it does 3 things for me to put one nice central groove in, okay? It's 10 seconds on the occlusal, and we have to get 3-point curing for full depth of cure. So I'm gonna remove this, and then we're gonna go ahead and cure this. Now here's the problem, and here's why almost nobody is bulk filling. You can't do this with a metal matrix. If you're using a metal matrix, you have to peel it back and remove the wedge. And what happens when you peel the matrix back? You get the ROB, the river of blood, right? And metal matrices actually are not reflective. They actually eat photons. And so metal tends to actually get less curing near the matrix. So obviously a clear matrix has advantages. You need to look for the BioFit matrix has a flange that goes away from the tooth that allows a quick release. Now, one of the neat things about Mylar is that it's easier to take the matrix off because of how smooth it is, right? So make sure and twist this in the dentiform because you don't have a periodontal ligament, but that's what we're after is that amazing shape with that super broad contact. Can you see Explore, please? A little bit of, so that's what we're after. We've just never seen that before in composite. So let's extract this and take a look, see how I did today. Now, when you do this and take the tooth out of the dentiform, you're going to notice that the Filtech Bulk Fill Flow has a little bit different color than the paste. But I did such a good job of injection molding that you don't see a lot of color from the bulk fill flow. We're going to do a video on this, but you're going to push 99% of the flowable out of there. That's almost completely Filtech 1 there. So anyway, that is the injection molded class 2. And so, we have got, Juan asked about shape. We've got several different matrices. The bicuspid shape is a little bit different than the bifid HD. So we can get a pretty ideal contour by using the push-pull, because this push-pull instrument will actually sort of morph the shape into either a flat or a rounder shape. So you're 99% of the time, you should be okay by doing, modifying the matrix adaptation by the push-pull. We've pretty much got a matrix for almost every shape now. So in the beginning, people would complain that there were too many matrices. and then after you start using it, like somebody said, hey, this is a good shape for molar, but I want something different for bicuspid. So now we have a bicuspid matrix. So you know, nobody's ever happy, right? Either there are too many matrices, or once you start using it, people want more. So we have had a good day here. I'm going to check in with all the panelists before we run off. And let's make sure, let's check in with Taras first. Taras,
David, that was really awesome. I really wanted to thank you for showing us that. I'm happy that McGill has seen that, and it's been just a perfect culmination to our Bioclear week. We had the staff, we had the students on, and I think that really it's been a really great demonstration, closing everything off. Thank you for your commitment today, working up so early. Thank you so much for uniting us with other universities, and we really appreciate it.
Great. This is recorded. Dr. Bustamante is going to hang around. Are we shutting this one down and go to a new Zoom? Can Bustamante hang around and answer a couple of questions? He's got to go to work on Monday because he's going to retire from the webinar business. All right, let me check in. I've got, oh, can you believe it? I got a 6-hour remote hands-on class. I got to start in 15 minutes. So we've got 20 doctors set up to do an all-day class. So I got to drink some coffee, go back to work, you bums. You're going to go take a nap. Nathan's sitting there in his pajamas, man. I know that.
No, it's from our side. Thank you so much for doing this. And I know some of our Robles and some of our students had to log off because they do this 9 to 10 o'clock webinar thing. But thank you so much for recording it, and thank you so much for taking the time to show us, not just do the lecture, but also do the hands-on. I know that's a lot of extra work, but I think we had when Mark came and kind of showed us the technique to some of the key people in restorative at our school. I think that kind of turned us on, and yeah, we have an opportunity now with some changeover to maybe start trying to implement some of this stuff. So thank you so much for doing this for us. And you answered a lot of questions. And I always just love to see you present. You can present anything, and it's always just so exciting. So thank you so much for doing this for us.
Oh, Nathan, you're very kind. I think you're a great presenter too. I've told you such. So it's fun to watch somebody else having fun doing this for sure. I want to check in real quick with Dr. Drummond and then Dr. Robles. Is Dr. Robles still here? You ran away?
No, he had to go leave.
So really quickly for the wrap
I just want to say I've been running the phone lines. We're trying to get everybody back for next Friday morning as well. So same time, same station. I'm trying to make that work for the students.
Great. We're going to do the tough class 2s, and we're going to go over some cavity prep design, deep margin acquisition. How are these students going to go on there and knock it out of the park, hockey puck in the net on tough cases, when to overlay the cusps, give you a whole bunch of clinical examples, and go through some exercises in the posterior. So next week, it's all about the tough class 2s, the deep class 2s. And then can UAB join us next Friday morning?
I think that I might not be able to, but I think everybody else should be able to.
Awesome. All right. Hey, everybody.
Thanks,
So
David.
Yeah, thank you very much, David.
This is really fun. All right. Take care.
Next week.